So I'm giving you a slight retrospect on coronary physiology. A lot of this information is not new. In fact, the information has been known for over 40 years in the majority of cases. These are my relevant disclosures. Coronary physiology has become very complicated. There are many, many different terms, and it gets very confusing on what we are talking about at any time. The principal message I'd like to for you to all take away is that coronary physiology is a tool for deferral of non-ischemic disease in stable patients. That is where we should be using it. In the context of acute coronary syndromes, in the context of myocardial infarction, it is less useful. In the situation where there are complex other issues, previous bypass grafts, competing vessels, CTOs, again, it becomes less useful to be able to understand. When there is a stenosis in a vessel, there is pressure loss that occurs because the flow is moving across the stenosis, and that causes there to be a gradient between the proximal and distal segments. And some of that gradient is generated because of friction loss, and some of it is due to marked separation. When there is a lot of pressure loss, it is easy for us to see. If we take a wire across the stenosis, you will notice a very, very large pressure gradient, and that is very obvious when we are treating coronary disease. When it is more subtle, it is harder to understand, and we can make errors. What we really want to be able to do is measure flow. The problem is, no company at the moment makes a commercially available flow assessment tool. Abbott manufactures a device that uses thermodilution, in which you can estimate flow, and Philips no longer makes the combo wire, which allowed you to do Doppler flow velocity, which could also be used to estimate flow. And there are a number of new competitive devices that are coming that are not yet validated. And because of the difficulty in measuring flow, we therefore have to use pressure as a surrogate. Pressure and flow are not the same thing. When we're trying to make a flow measurement, most of the time we are measuring noise. I had the privilege of reviewing some data shared with me from the United States from a very eminent lab in the past, and they asked me to do a flow analysis on all of the work they had done. And unfortunately, as I went through all of the traces, I was disappointed to see they'd measured noise in over 200 patients. This is a common phenomenon. It is hard to make a good flow tracing. So we're back to measuring pressure. Pressure is easy to measure, but we have to overcome the limitations of autoregulation and basal flow in the coronary vessels. Our bodies are designed with homeostasis in mind. We want to maintain stable flow at all times, even in the presence of a significant coronary stenosis. The way we do this is our microcirculation dilates. It vasodilates such that flow is maintained regardless of stenosis. This is autoregulation. When we're trying to assess a stenosis, we have the ability to use two different technologies. One is to induce hyperemia, which is with the addition of a drug called adenosine, which you'll be familiar with, and in the Far East they use papaverine. Or you can make a very clever measurement in diastole, and I'll show you why we do that in a moment. And the reason we are doing these is because we are trying to remove resistance from the equation that pressure can relate to flow if we can keep resistance stable. Resistance does not have to be low in order for this to be equivalent. It just has to be stable. So I'm going to show you these flow graphs, which are quite difficult and confusing to understand. But if you can get these into your head, you will understand everything there is to know about epicardial stenoses and coronary physiology. Pressure and flow have a quadratic equation that relates to them. We can see that as flow increases, pressure will be higher across a given stenosis. If we drive pressure higher, flow will be higher. These two things make intuitive sense. Every single stenosis, whether it be a 10%, 15%, or 90% stenosis in a vessel, generates one of these curves. The problem is we do not know which curve it is generating, and we have to try to work it out based on these calculations. Even when there is no stenosis in the vessel, if you give enough flow, there will be pressure loss. Those of you who've put a pressure wire down a normal coronary vessel will find that the FFR is not 1 when you give adenosine, okay? And this is despite the fact that we are all taught that a normal FFR is 1. and that is due to resistance and pressure loss within the vessel. So when we're making a measurement, we want to create certain circumstances that have relatively good flow characteristics. If I make a measurement of a pressure gradient at 25 millimeters drop, so an FFR of, say, 0.75, highly significant, we do not know whether that stenosis is severe, moderate, or mild because all of the curves intersect that pressure gradient. So if we increase the flow and push the flow up, then the gradient becomes more and more obvious, and it's easier to understand and detect that stenosis. But it is important that we keep our process consistent. We should stick to a single dose of adenosine and not vary it, because if we alter the doses that we give in an attempt to increase the flow and make the number lower, understand that all you are doing is pushing the curve further along this, and you are not actually understanding true ischemia. You are fooling yourself. So fractional flow reserve is a long-established technique in which we infuse adenosine and make a pressure measurement because we are making the resistance low and therefore increasing flow and dropping the pressure gradient. There are other ways of making these measurements as well. Pressure and flow relate to each other in a complex way. In the aorta, it is quite simple. Pressure and flow have a close relationship. But in the coronary arteries, it is very complicated. This is because most of flow is in diastole. The coronary circulation and microcirculation is compressed during systole, such that flow is attenuated. And you can see on this red pressure trace that the majority of the flow velocity is in diastole. And if you look at the relationship between these curves, you can do something called wave intensity analysis, which allows us to understand where there is resistance in the coronary circulation. And you'll understand that within a single heartbeat, there is a period in diastole in which resistance is low. It is not the absolute lowest, but it is low and it is stable. And if we make a measurement there, you'll see that pressure and flow are linearly related and fall together. This is why we can make measurements in diastole and understand the significance of a coronary stenosis. This is how we developed IFR over 15 years ago at Imperial College through this observation. My supervisor at the time, Justin Davis, had spent 10 years understanding wave intensity analysis when he discovered that actually the waves were not the important part, but it was when there were no waves that you could understand when a coronary stenosis was significant. And what is interesting is if you make measurements of pressure and flow at that time, you'll note that at rest, within a single heartbeat, your flow velocity is its highest under resting conditions. And so therefore, you meet the criteria for being able to tell whether a stenosis is significant or not. So we have these two competing technologies, IFR and FFR. Both are established now, and there is no doubt that they both play a role, and they have their own utility. Neither is perfect, and each has their own limitation. IFR is a resting index, and it is measured at rest over 5 heartbeats, and it will give you an average value. I'd recommend that you make multiple measurements because there is a subtle perturbation that can occur according to where your wire is, and you must give intracoronary nitrate before you place the wire because you are trying to stabilize the epicardial vessel, and this does not induce hyperemia. It does get confusing because all the companies now have developed their own iterations of this, and this is a mark of how successful the technology has been, that every company now has its own variant. I would say that they are essentially the same as IFR. And that is because when you look at the indexes of what they're measuring and where they're measuring it is essentially in diastole. There are subtle variations. This has got nothing to do with science, but more to do with patents. So IFR and FFR are recommended for coronary revascularization in both European and American guidelines. And it's generally recommended when you have multi-vessel disease or you have not performed ischemia testing before the patient's got to the cardiac catheter lab. In the United Kingdom, because almost every patient now has a CTCA before they come to the cath lab, it generally means that we use pressure wires a lot because they haven't had MIBI scans or stress echoes or perfusion scans as they did in the past. The work is well validated and the outcomes are very secure. We know that fractional flow reserve matches stress echo, dobutamine, thallium scans very well. And we know that when you compare IFR and FFR against any other metric of ischemia, they match incredibly well with no difference in repeated multiple studies. We also know that when you take a patient who has multivessel disease and you perform revascularization guided by FFR, the outcomes are better. This is principally driven by the quality of your stent result. When you use FFR, you use less stents. Less stents means less restenosis and less MACE events. And this was the original FAME study. And the opposite is also true. When you take patients that have confirmed ischemia on fractional flow reserve, you'll note that patients are less likely to come back into hospital if you revascularize them because you reduce ischemic events and MI. IFR has also been tested in now 2 very large randomized control studies, a defined flare and IFR sweetheart, total of 4,500 patients. The 1-year, 2-year, and 5-year outcomes are very satisfactory with no difference between fractional flow reserve in these studies. And the safety outcome, certainly from the Swedish cohort, has been well proven, and 5-year outcome data shows no difference in outcomes in these studies. But the defined flare study did show a signal of harm, which is worth considering and reflecting on for a moment. There was a separation of the curves out to 5 years, which raised concern. However, when you look at the data in a deep dive, you'll find that the difference is in the patients that were treated. If you'd expect IFR or any of the other resting indexes to be causing a problem, you'd expect it to be in the deferred arm, i.e. the patients that you have not treated with revascularization. In this study, all the patients that had a poor outcome were in the patients that had PCI, and therefore this is most likely an erroneous finding or a chance finding rather than a true signal of harm. The future of where we go from this in physiology is not to say patients need a stent or don't need a stent. The idea is to try and understand where we should be placing the stents and to understand whether we are doing a good enough job. We all know that when we perform coronary revascularization, a lot of patients come back with angina. And some of these patients have ongoing ischemia. And the defined GPS study has shown that in the majority of these patients, it is because we have not stented sufficiently within the vessel. And the solution for this is to use the technology in a different way. We're dealing with much more complex coronary disease than was ever considered in the original FAME studies. And we're dealing with patients that have complex lesions like this, in which there is a long segment of disease in the LAD that extends all the way from the proximal segment, and there is a tight focal stenosis in the distal vessel. And an interventionist may be keen to place a single stent in that location because there is isolated pressure loss there. But if you use the IFR technology with a pullback and you co-register it as it's being performed in this image here, each of these areas shown with a yellow dot represent areas of pressure loss. These can help guide us where we should be targeting our intervention. If we simply place a stent here to cover this very small lesion in this focal area, we would only be gaining 8 units, and therefore the patient would still be highly ischemic, and therefore we will not have helped them. Experienced interventionists will know that actually you'll need to cover the vast majority of this disease, and IVUS and intravascular imaging technologies help guide that. And so the workflow I'd recommend to all of you is, whilst we're using physiology, use it intelligently, use it in combination with the other technologies. It is not there to supplant, and use it in a way that will achieve a negative physiology at the end of your revascularization procedure. So I can conclude that pressure and flow and resistance are complex, but it is easier to measure pressure in your day-to-day workflow. We have multiple tools to be able to assess, and this can include non-invasive technologies, but once the patient is in the lab, it behooves us as interventionists to identify where the ischemia is and what can be done about it, and that can be readily performed using either IFR or FFR, and even though we are the originators of IFR in our particular lab, we have no strong view on whether you use one or the other. We know that the studies have demonstrated equivalent outcomes, and we have established clear cut points. But remember, ischemia is not a binary go, no-go, stent, no stent situation. It is a constant spectrum, and therefore be guided by your patient and what you feel is best for them. Thank you very much.